Hello, everybody, and welcome to the Heroes Like You podcast, where we explore the lives of people just like you and I who've had to overcome challenges in their lives and have gone on to accomplish great things. My name is Joe Belliston, and today's episode is going to be a little bit different. Our hero today is Dr. Doug Gray, who's a professor of psychiatry at the University of Utah and who has spent the past 30-plus years studying suicide specifically and what we can do to prevent suicide and help those who may be struggling with depression and suicidal thoughts. I had a great conversation with Dr. Gray. He's been very gracious over this past year as we've corresponded by email to answer a lot of my questions as I've tried to understand this important topic. In this conversation, Dr. Gray explains some of the research that he's done and gives us some very practical and useful tools that we can use as we try to help people through dark times. He also shares a couple of great success stories that he's had with patients over the years. I hope you enjoy it. So without further ado, here is Dr. Gray as he and I sat in his office and he answered some of my questions and helped us get to know him a little bit and the important work that he's been doing. Well, Dr. Gray, thank you so much for taking time and being willing to be on the podcast with us today. First of all, let's get to know you a little bit. I know that you've spent the last 30 or so years here at the University of Utah studying suicide and possible measures to prevent suicide. But what is your current role here and what is it you do?
So I'm a professor of psychiatry at the University of Utah. And what I enjoy most is working with medical students and residents. So I'm the vice chair for the Department of Psychiatry, and I'm in charge of the medical student training and the resident training. We train a lot of different types of doctors. And then my research interest is learning more about suicide so we can learn how to prevent suicide. And so I'm interested in anything that's suicide prevention or anything we can learn from those that have died by suicide that might help us to design better prevention programs.
So what prompted you to study psychiatry and then specifically suicide? Was there something early in life or an experience you had, or what was it that prompted you to do that?
You know, I would say just the opposite. I was in medical school, and I was pretty sure I wanted to be a pediatric doctor. I love working with kids. I was looking at pediatric subspecialties. I was looking at surgical, pediatric surgery type subspecialties. And then I only did the psychiatry rotation because I had to. It was required. And I loved it. It was so interesting because you'd see a patient from one walk of life and they'd have these hallucinations, but they'd describe them. And then you see a patient maybe of a different, one would be a man, one would be a woman, one would be, struggling financially, the other one would be wealthy, but they'd have the same hallucinations and a lot of the same symptoms. And I could look them up in the DSM and see the constellation of symptoms that gave them a diagnosis. And then I could see treatment work, and it was like, this is remarkable. I mean, the heart is an interesting organ, the kidney's interesting, but the brain is more interesting. And then I thought, well, okay, I love that rotation, but I'm a pediatric doctor, basically. I was sort of built for that. I love kids. So I went and did a child psychiatry rotation, and I just loved it. And I actually went to one of my friends who's an ICU doc, and I said, I feel embarrassed because it doesn't feel like work to me. He goes, oh, it's work to me. He said, I could never do psychiatry. I did that rotation. I couldn't wait to get off. And I go, really? He said, yeah. And I thought, you know what? It feels natural to me. It's a fit. And I enjoy the patients. I enjoy helping people, enjoy watching them get better. And so I was shocked that I enjoyed providing mental health, and I really did enjoy it, and that's what I chose as my career.
So it's been about 30 years, right?
Yep.
And you've enjoyed every minute of it.
I have. I mean, there's always, red tape and bureaucracy and things like that, but it's minor in comparison to helping so many patients who maybe start after a suicide attempt or they're feeling suicidal, they're brought to an emergency room, and then to see them through to where these are teenagers who they grow up and they go to school and they have jobs and they have kids and they come back to say hi to me, and to see that kind of, let me say it this way. I have medical students work with me and they keep saying, wow, all your patients are getting better. And I'm like, you're surprised?
Isn't that the idea?
Yeah, but they just think that people with these illnesses are all chronic and they don't get better. And there are some, just like, there's chronic kidney disease and there's
Sure.
chronic medical. But so many of my patients get better and do well.
Well, let's talk about some of the research you've done regarding suicide.
Sure.
Suicide over the last 20 years has increased pretty significantly. And I'm sure you know the stats better than anybody, but it's the second leading cause of death in America right now. State of Utah, where we're at, it's the leading cause of death for people between 10 and 30.
Yeah.
The rise, the increase, it's risen 33% since 1999. In 1999, there were just over 29,000 recorded suicides. 2017, I believe, it was just over 47,000. So it's going in the wrong direction.
Yes.
I believe. So from your research, what have you found contributes to that? You've been in this space for 30 years.
Yeah.
What's contributing to the increase in suicide, especially in young kids?
So I've got some good news and bad news about the science. So scientifically, we've really put together a good list of risk factors that increase risk. So we can say, this patient has this many risk factors, this other one has more. We can see the risk is greater. But completed suicide's an infrequent event, even though the rates are going up.
And what's that rate?
Well, it depends on the age group, but it can be 20 per 100,000, or for kids, the rates for kids are lower, but the years of life lost are greater.
Right.
So that's going to be much smaller, maybe 13 out of 100,000. It's a little interesting because people glom together suicide attempters and completers, and attempting peaks at about 15, 16 years of age. So when you get to looking at adolescents, there's probably 200 attempters per every suicide decedent. Let's talk about the good news. So the good news is we're learning a lot about suicide, and we know who's at risk, and we can better address those risks. So that's good. The bad news is, in the last decade, 15 years, we've had this rise in suicide rates in adults, in kids, and the honest truth is we don't know what it is. And I'm always straightforward. I can tell if you bring me an individual patient, I can tell you their risk. Now, here's some hypotheses that are very reasonable.
Okay, let's talk about that.
So we know that in America, there's an opiate crisis. And besides opiates causing accidental overdose deaths, opiates also can destroy lives and lead to suicide, right? We also have data that shows among adults there's a binge drinking epidemic. So we have that. And then we have, this suicide crisis. And I think they're all related to some type of hopelessness. This is theoretical. Nobody can prove this, but we know that Americans are struggling with higher rates of anxiety and depression than they were in other generations. Especially the young people are very anxious. So what is that? And I think that those are all tied together. I've talked with political scientists who believe that the separation between how much wealthier the wealthy are compared to the poor, that gap, and how wide it is in the United States. There's some data it's not proof, but some people believe that that's part of the problem, that the middle class is disappearing, and the people who are struggling financially don't see hope for themselves. And that's especially true in rural America, where suicide rates are higher. So that's a current theory. We can't prove it, but that's the current. But gosh, we have an opiate epidemic. We have binge drinking epidemic. We've got a suicide epidemic, and it's all tied together somehow. When you look at other theories, we know that in industrialized nations, people are often lonely or isolated. There's a lot of that. England just announced that they're going to have they appointed a minister of loneliness. Someone will help the whole country try to figure out, can we get elderly people connected to young kids? Can we get different generations interacting more instead of everybody being isolated in their houses? And of course, their kids live elsewhere, their grandkids live elsewhere. But can we create a community for people so they're not so isolated? That's another theory. When you get down to the really to the children and teenagers. There are theories about social media having an effect, that everyone appears to have a perfect life, and of course nobody really does. Life is difficult, life is hard, and when people find difficulty in their life, they sometimes feel like everyone else is doing well but them. And that's why I like the idea of your podcasts. I really like this idea of finding people that have struggled and have fought their way through, because I think that's what we need to get out there. I think that's really helpful. I think the other thing is for people to have different expectations. I think Teddy Roosevelt said, expectation is the thief of joy.
Right.
And I think we have a lot of that going on. Now, because I'm a scientist, even though you can find published articles that say that kids with more depression and anxiety are on social media more hours, okay, that's a fact. But I would say, which came first?
Right.
Are people that are anxious and depressed, do they get isolated and spend all their time on social media? Or does social media itself, is that causing problems? And it might be both, so we don't know. So I think we're really good. Like, I can tell you for sure that if you have an untreated mental illness, you're at higher risk for suicide. I'm positive of that. I can tell you that there's a genetic component. If you look at your family tree and there's a lot of people who have died by suicide, you're at higher risk, I promise you. Now, the risk is still low, but it's there. If you add substance abuse, any kind of substance abuse to a mental illness, now you're going up exponentially. If you have loaded guns in your home that aren't secured and you have access to them, no question that increases risk. No question. So we know a lot. We even know, this is great science that's new, that you may not have heard of, but we've always known that the Rocky Mountain states have much higher suicide rates than the rest of the United States.
Higher elevations, right?
And elevation, the altitude hypothesis. And that came out of the University of Utah, Dr. Perry Renshaw and colleagues. And basically, up to about 2,000 feet, no difference in suicide rate. As soon as you get to 2,000 feet and you go up, the rates go up and up and up. And Dr. Renshaw is actually, this is how you know something's biological. He's taken rats and put them in hypobaric chambers at different altitudes. And then he's got a depression test for rats. It's another long story. But anyway, the rats who are at higher altitudes have more depression. And he's actually found some medicinal treatments for those rats at high altitude where they're less depressed. So when you can do it with an animal model, there's a strong biological component. So it's not just that people at high altitude are more likely to be independent or drive pickup trucks and do their own thing. You can have other theories, but when you can do it with a rat, it's there's a strong biological component.
Yeah. So the truth is, we know that suicide rates are increasing, and there are a lot of hypotheses out there as to why, and we know certain risk factors, but the reality is we don't know why we don't have clear evidence why rates are increasing more now than they were before.
We know the factors that lead to somebody taking their life. We don't know why those factors, some of them unchanged, and yet the rates keep going up.
Okay.
Now, I will say that the bulk of the suicide increase has been in 45 to 64-year-old white men that have high school or less education. And my guess is that, especially for those folks in rural areas without education, that life's pretty tough right now. And whatever they expected life to be like.
These are golden years. They're supposed to be at the peak of their careers, right?
Yeah. And you know what? Utah's booming, so that's where that doesn't always fit. But I went to Gettysburg because I've always wanted to go to Gettysburg, and my wife and I are driving through Pennsylvania, and these factories that were shuttered, and then homes where the paint was peeling off, and you could just sort of feel that these areas were decaying, and how hard it must be for folks that, were used to working hard and making a nice living, and those jobs have been moved to, other countries where it's cheaper to manufacture things. So I think we're...
Would that have to do with a sense of purpose, maybe? Losing a sense of purpose?
Well, we know that it's sort of interesting. Women are more immune to economic changes. Men are more sensitive to that in terms of suicide. Interestingly, elderly men are not affected by it very much. They may value themselves in a very different way. And young men earlier in their employment, in their 20s and 30s, are probably more affected. These are based on studies done around the world. So, my hypothesis, I don't have evidence to prove, but my hypothesis would be it's something to do with our changing economy that's affecting white men who are uneducated, especially in rural areas. And and I'm not going to be political at all in this talk, but it may explain, the last election, presidential election, the desperation and the frustration that people are feeling, and the kind of changing course politically from anything we've ever had before. So those are some of the theories. So if you brought me a patient in the emergency room, I could assess their individual risk pretty well, at least tell you whether they're low risk or high risk. I can't predict whether somebody will suicide or not, but why suicide is increasing, that's a puzzle. We've got some really good theories, but we just don't, know for sure.
Interesting. And I've got my own theories and hypotheses.
Oh.
But I want to talk to you a little bit more about, you were talking about isolation.
Yeah.
England has a loneliness
A minister of loneliness.
Minister of loneliness. We know that suicide really comes down to hopelessness, right?
Yeah.
In the end, that's what it is. I just have lost all hope of any bright future.
Often these patients will feel like they're a burden to other people, and they don't feel like they have a lot of self-worth, even though the people around them disagree. That's where their head is at. And so, yes, those are some of the risk factors.
Well, I want to talk more about isolation. So
Sure.
It's interesting that suicide rates are higher in rural areas where there's not as many people. And you say it's increasing in teens. The highest suicide attempts are in teens right now.
Well, that's always been true. So
okay.
I was just letting you know that suicide attempting peaks in the teenage years.
Okay.
And sort of really slows down after the young adulthood.
Okay.
Whereas suicide completion or suicide death, the highest rates are in 45 to 64-year-old men.
I can't help but think that it does have something to do with technology in some regard.
Yeah.
In social media, we're seemingly more connected than ever. I can talk to someone clear around the world in a matter of seconds and see them.
Yeah.
In social media, I can know more people than I've ever known before, and yet it's not a deep connection. We're seeing more isolation, and possibly, you have parents that are on their devices ignoring children. But I see all around me, teens especially, just hunched over by themselves with their devices. They may feel connected, they may be getting these dopamine drips, but the face-to-face is missing. We're connected, but we're so isolated at the same time. Would that?
Yeah, it's funny because it's probably different for different groups of people. I'll give you an example. If I'm seeing patients, I want to see them in front of me. I want to form that but I want them in my office.
Yeah, of course.
But the young doctors I'm training, I was telling a small group of them that, isn't it great that we can provide rural Idaho through a contract we have with some telepsych to provide some care. And they said, no, what would be really great is if the person that lives right across the street from the hospital didn't have to, dress up and drive to the hospital and try to park and wait in a waiting room. Wouldn't it be great if they could just get on an encrypted Skype type of a communication, and we could just do the appointment while they're in their apartment?
Okay. What's the difference?
And I'm like, that doesn't work for me. And they smile because I'm their boss, so they don't want to say, well, things are changing, right? But I'm telling you that they're more comfortable. I don't know, a lot of the kids I used to see in my practice, they might connect via a video game, and they had friends in Australia and all these places. And I would say, yeah, but you're just playing a game. They go, no, we have these little chats, and we actually share some pretty important things. But they had to admit to me that they're never going to see those people in person. And I do think it's different.
No, I think you're right, though. I think there is a difference.
Yeah.
And it's great, the technology advancements that we've had, and we can communicate better and with more people more instantly. But
Yeah.
I think, I mean, you try it.
You and I are going to agree, I think, that real contact with real people is
Yeah.
meaningful and more meaningful than through a screen. Or
That's why you still
Yeah.
travel to do business contracts, right? Face to face with a handshake. And there's nothing that beats that through a screen, through technology currently. I
Yeah.
don't think. I mean, that's my opinion.
Well, you and I agree, but there are young people who say, I can do that business contracts
true.
but I think something's missing. But that's an opinion.
Right.
Yeah.
Well, let's talk about the adolescent brain that you've studied.
Yeah.
I've read that the brain doesn't fully develop till about 25.
Correct.
Is that right?
Correct. It's
Okay.
still, if you imagine, you look in your house and there's some device that you plug in, and there's maybe copper wire in the middle of it, but it's got a sheath around it, like a rubber sheath or plastic or something. So in the brain, a lot of the parts of the brain that you want help you with judgment and making good decisions, those nerves get wrapped in something called myelin, and that myelination, continues till you're about 25. Now, after that, you still have lots of experience that changes how you view the world,
Sure.
and how you think.
Yeah.
But as far as like mechanically, the brain looking a lot different, no, it's fully developed. And if you think about how different you were or I was at 18 versus 20 versus 22, huge differences.
Huge difference.
Yeah, and 24. As opposed to, the difference between 30 and 32 and 35, not much difference.
Okay.
Yeah.
Yeah, and there are laws that have age requirements, right? You can't drive till you're 16 in most states. You can't smoke till a certain age. You can't drink till 21. I don't think you can rent a car till you're 25.
Yeah.
Right? And these are all put in place for our benefit, for our safety.
Yeah.
Because like you said, our judgment is different at different stages of our lives. So what is the impact on handing a child a device that has access to everything on the internet at too young of an age?
Well, I think one of the things that's difficult is the studies, and when you have studies, you start with people that aren't on the internet a lot and people that are on the internet all day long, and they may be self-selected for those things. And what we really need is randomized studies where you take two groups, and one of them you have them doing social media at least 4 hours a day, and the other one doesn't get social media, and you do that for a year, and then
Yeah.
And so right now what we do is really imprecise, which
Sure.
is you look at the people that spend more time on social media. Oh, guess what? They're as a group, statistically, a little more depression, anxiety, more problems. But
Okay.
again, which came first, the chicken versus the egg? So I think this is all happening now, and I don't know that we know of all that. At the University of Utah, there's a study called the ABCD study. Dr. Yergel and Todd is doing that, and they're following young people and scanning their brains throughout development, following them all the way up into adulthood. And it's those kind of studies where we can start with a baseline and follow their every influence and kind of what happens to them, and look at nature and nurture both. Those are the kind of studies, and they're expensive studies, but those are the kind of studies we need to answer some of your questions, which are good questions.
But as far as, introducing something too early for an adolescent brain, I mean, you wouldn't introduce your 12-year-old son to alcohol, right? So is introducing these
Sure.
things, is it potentially damaging, or can the brain handle it? Or do we, just like you said, do we just not know?
I think it's like everything. It's kind of how much and how early. And
Okay.
so, all of us have had dinner guests, and the kids are, raising heck, and we put them in front of a TV to watch a Disney movie, or we let them play on the iPad. That's probably fine,
Sure, yeah.
But what really matters is the long term, like how much time are your kids spending on the screen, and how much are you getting them outside? Are you getting them, are they active socially with other kids? How much is too much? I mean, I think good parents will collect devices at night, like in the kitchen, and the kids go to bed, but they don't go to bed with the devices. And they don't have a TV in the room, and they don't, I think good parenting involves trying to keep a balance. Good parenting is sitting up at the dinner table and have everybody together and talking, and not doing dinner every night in front of the TV, for example, or everybody's doing their own thing. So I do think it's up to parents to try to provide a balance for those kids. And I do worry about excessive screen time. But, hey, a lot of education is coming through those screens
Sure.
too, and a lot of positive. People are looking things up for book reports. They're, can't solve a math problem, and they're going on the internet and finding the solution.
Yeah.
So it's a cross between not wanting to overdo it, but making sure your kids are ready to compete with other people's kids when they, in terms of education.
So in your opinion, and from your research, do you feel like those things you just mentioned, eating together as a family, having more balance, going out and being with people socially, being outside, do you think that could potentially help in reducing depression and suicide?
Yes.
Or is it so
But it's
individual?
it's just one component. So I'll just give you an example. So I think I can help more by talking about how we approach evaluating any patient.
That would be great.
So we have the biopsychosocial model. And biology, and usually it's a mixture, but let me talk about a case that's pure biology.
Okay.
Had a teenage patient who had a really good life, and nothing bad has happened. Nothing. And good student. And grandma fell into a deep depression at 16, long time ago, and required medication to get out. And then mom had the same thing happen at 16. And now this 16-year-old girl, third generation, just dived into a depression for no reason. Well, that's very biological. And the solution is probably going to be medical. Does that make sense?
Yeah.
Okay. So
it wasn't outside influences that were causing depression.
In this case, I'm talking about a pretty pure case. She loved her life. She liked her friends. Her grades were good. She was just sad all day long.
Right.
And struggling with even some suicidal feelings. So biopsychosocial, psycho is psychological. So imagine someone that, let's say they're Chinese and they're the only son of this family and they're expected to do great in school and they get a B or C on a test, or they struggle with their ACT test, and they might, with the kind of cultural pressure to do well in school or to succeed, they get stressed and start thinking about hurting themselves, even though most students would love to have their grades. But for them, whatever reason, they failed in the eyes of their family. So biopsychosocial, the social, so you have a parent die, you have a breakup with your girlfriend, you're out partying with your friends, you get arrested, and now you got to go to court. You break up with your girlfriend and all your friends were her friends and they take her side, now you have no friends. You're trying to get into college, but you're failing a class. Those kind of stressors. So typically when we look at the biopsychosocial aspects of any patient, typically it's a little bit of this and some of that, but then you try to figure out which of these three is the biggest.
Right.
And so if it's psychological, you're always going to want to start with therapy, right? If it feels more biological, you may want to start with medications. And then if that doesn't work, go to therapy, for example. And if you start with therapy, maybe go to medicines if those don't work. And then if it's social, can you bring the parents in? Can you bring the family? Can you create some changes? Maybe it's dad's alcoholism that's creating the stress. Well, bring dad in. Hey, I'm not against you or for you, but this is having a big effect on your kid. Is this something you're willing to let me refer you to somebody for? Are you ready to get some help? So we use that biopsychosocial model. It's often not clean. It's a bit from each category. Mm-hmm. And then we try to figure out what treatment might be best. There are very specific kind of therapies now for different kinds of problems. And they're very effective. And we try to choose the right treatment. And if it doesn't work, we don't sit still. We do something else. We move to a different type of treatment. We give it a certain amount of time and then move forward. So that's kind of the general approach. And of course, today, before we end, sometime I'll tell you that if a kid is at risk, we really want those parents, if there are firearms in the home, to reduce access or eliminate access, whether it's a gun safe or, grandpa has a lockbox and take them there. Especially while that kid is struggling to not have access to firearms, that would really bring down our suicide rates.
That's great. That's good stuff. I want to bring this up. You talked about having TV in the kids' room. CNN recently released an article about the Netflix series, 13 Reasons Why.
Yeah.
And what they found is that there was a spike in suicides in teens the month after that was debuted.
Sure.
And they followed that through the year, and there were approximately 200 more teen suicides than there were the previous year.
Yeah.
And they're very careful to say there may not be a link at all to that, right? What's your opinion about that? Is that something that's glamorizing suicide, or is it the fact that it's being introduced to people that as a way out that may be increasing suicide? Or what is that?
You're right that we've always known that publicity about suicide, or especially if it's glamorized, especially if they talk about the method of suicide, for example, increases suicide rates. So separate from 13 Reasons, we've already known from other really good studies around the world that, and we know that if that headline is in the front page rather than the third page, the risk goes up. And if it talks about anything romantic, the person, drew a heart in the snow and wrote their girlfriend's name before, anything like that is going to increase. We're going to see a spike in suicide rates. That kind of copycat suicide that we call, suicidologists call contagion. The groups that are especially vulnerable are the youth. So probably 15 to 24 years of age are the most vulnerable. So when I get a call, I'll get a call from a school and they'll say, I'll make up a name, Johnny. Johnny was our star, let's say a basketball star, and we want to have, he died by suicide, we want to have a thing in the auditorium, we bring his parent, honor him, talk about his best kid ever, and
Sure.
we lost him. And I say, I totally get why you want to do that. But you may create a problem and you may have more suicides, and it's going to be on you.
That's so interesting.
And I can't tell you what to do. I'm just telling you what the repercussions are. You have to make your own decision. I don't control what schools do. And they say, well, what could we do instead? And I said, well, what you might want to do is, does everybody know he's, yeah, they already know, everybody knows he's dead, and everybody's heard that he suicided. So I say, well, you go into the classrooms, maybe you have each teacher talk to the students, and you say, we all like Johnny. He's a good kid, but he made a really bad mistake. He made a bad mistake because if he asked for our help, we would have helped him. And he was too afraid to ask for our help or didn't think we'd help or something. But we want you to know that if any of you are in distress and you're thinking about hurting yourself, come to one of us. We'll talk to you. We'll make time. We'll be available to you.
That's so good.
And it has to be like that. So, there are good kids, really good kids, who maybe it's the first time they've ever been drunk, and they drive, and they might get in an accident, and they might get hurt, or somebody else may get hurt. Doesn't mean they're a bad person or a terrible person. To some extent, if they haven't done that a lot, they're maybe just unlucky, because people have to drive drunk many times usually before they get in an accident. But we don't want to, we want to say, if Johnny, kills somebody in a car accident, it's a mistake a lot of people have made. This outcome was terrible. Johnny's not a bad person, but he made a bad mistake. And suicide's the same way. But you don't want to glamorize it. And if people don't know how he died, you don't want to say how, what method he used. So you want to be cautious about anything in the media. The problem is some people suicide because they're suffering with mental illness and they just get worn down, maybe not, and mostly not getting help or undertreated. But some suicides are more a statement. I remember in the Vietnam War where people would set themselves in fire right in front of the Pentagon. They weren't, who knows how much they were suffering with mental illness, but they believed in something so strongly they were making a statement. And there are some suicides that people make a statement. And, especially if someone's media says, oh, this kid was bullied and that's why he killed himself. And then some other kid who's bullied say, well, maybe that's what I should do. As opposed to, no, you tell somebody you're bullied, we're going to help you. And if they keep it up, you need to come back to us. We'll help you more. And I'm really excited about our Safe UT app that we have at the hospital here, because parents can put that on the kid's phone. The kid can put it on their phone 24/7. If they're feeling they're in crisis, they might hurt themselves, they can text. Again, I'm an adult. I want to talk to somebody if I was suicidal. But these kids want to text. So they text and they get a licensed clinical social worker. Somebody's can provide really good crisis care. And it turns out that besides suicidal crises, we've also gotten tips about bullying. That, Sally Mae's getting bullied by these kids. Here's their names, or she's at this school. Can you do something to help her? And yes, we do. We call the school and get help for Sally. And also, there have been some kids who've threatened violence in the school, and through Safe UT, they've texted our crisis workers who alert the police. And in some cases, they go to the house and this kid has firearms or other kinds of things that, really concerning. Who knows if they would have acted, but because of this tip, we're certainly able to reduce risk substantially.
Yeah, that's neat. I read something the other day that there was a threat that was prevented because of the Safe UT app.
Yeah.
While we're on the topic, though, we're talking about suicide with people or getting help from somebody. I think there's a misconception that if someone's struggling with suicide, or even if they're not, we don't even want to address the subject for fear of giving them an idea or something like that. What's the importance of talking about it with people, and how does that help?
So there are various programs where we call gatekeepers, people that, for instance, might be a school teacher, a school counselor. One of them is called QPR, and basically you learn how to, question, persuade somebody to get help, and then refer. But you have to get comfortable. Like if I were talking to you, and let's say I was a school teacher, you were a student, if I say, this is really hard to ask, and I'm really nervous, and I don't know, but are you suicidal? Is that going on? And they can tell you really don't want to hear the answer. They go, no, I'm not, Whereas if you say, Tom, you've told me you're depressed, and a lot of people who are depressed have suicidal feelings. Has that happened to you? Yeah, I've had some of that. Are you feeling that way now? No, not right now, but last week when I was having trouble with my friends, and that's kind of resolved now, but I was struggling with some suicidal feeling. Okay. So we don't want that to happen again. Would you be willing to get some help? Yes, I would. Well, would you let me help, connect you to the right people? We can get you some, I need to talk to your parents because I'm not going to exaggerate what's going on, or we're not going to create a crisis, but we do need to get you some help so you don't go to that dark place again. Let's work on that together. But you have to so we train people how to ask it in a way where they're just, like, what did you have for breakfast today? Have you had suicidal feelings? And people can tell when you're calm and you can manage the answer.
Sure.
People don't want to distress you with their answer, if that makes sense. So we actually have, there's QPR, but there's a first aid, mental health first aid. There's other, but we have, there are programs out there where we might train school teachers, counselors, people that work at businesses to get comfortable asking those questions, and then to know what to do. And then got to have a protocol available so that if this happens, here's what you do. And if this happens, you do this.
But that's always better than not saying anything, in your opinion.
It is. Interestingly, our huge advocate in the legislature is Representative Steve Elison. And he and I passed a law this last year that if it's a Good Samaritan law, but instead of being for car accidents, if you're out there somewhere and somebody's distressed and you stop to help them and you ask them if they're suicidal, and they are, and you do your best to help them, that if it goes bad, if they run off or if they end up dying or something happens, that you're completely free of any liability because you're a Good Samaritan doing your best to try to help somebody. I know a lot of people up till now and most people don't know about the law, so we can get the word out there. But a lot of people up to now, like a school teacher, somebody say, well, I'm not going to ask because I could lose my job. It's really not been clear what the liability is, and you care about kids, but you don't even know if the kid's suicidal, but you're afraid to ask for fear that you're putting your job on the line. You got your own family to take care of, and
yeah,
well,
that's good. Well, let me end with this. Besides those things that we've just talked about, what do you feel are the best things we can do to help someone who may be suicidal or who may be depressed, or even if they're not, just going through a dark time in their life, really struggling? What can we do as family, as friends, to help them get through this time? Because I've read too that if there's a suicide attempt, there's a higher chance of them later dying by suicide, but
Sure.
most don't. Correct? Most people that attempt suicide don't go on to die by suicide later.
It's a right.
So if they can get through that
Most people
time,
smoke marijuana, don't go on to opiates.
sure.
But some of them, it's a gateway to the next thing.
Yeah.
But most don't. Yeah.
So if we can help people get through this dark time in their lives, there's a great chance they're going to not only make it, but they could go on to live a great life, a successful life, and find happiness and joy and something they never thought they could.
So I think the first thing is getting comfortable with asking people, Sally, you look sad. I know I work with you. We work together, and if you don't want to talk to me, that's okay, but I just noticed you look sad. Are you okay? And Sally says, I'm struggling. I've been struggling. I'm stressed and blah, blah, blah. And I've got some depression coming back, but I can't miss work. And, well, Sally, we have insurance. Have you thought about getting some? Oh, I'm just too busy, blah, blah, blah. And, well, I know you're busy, but I think your health has to take priority. If you don't have your health, the whole thing could tumble apart. And you may even have to tell your boss that you've got to go get some health care, whether you tell them what that is or not, or her. But it's that kind of walking with someone down a path, and you're trying to get them to a better place, and you're willing to ask the questions and then to check on them and to see then if they got help and how is that going, and are you happy with your therapist? No, I don't like my therapist. I quit there. Would you be willing to try someone else? Well, I already tried therapy. Well, you know what? If you had heart problems and you didn't like your cardiologist, would that be the end of it? Like you wouldn't get any help? No, you'd go back, you'd find a better cardiologist or somebody you click. So you need to do that with, so it's that kind of encouragement. I think sometimes you first have to decide if somebody's struggling and it's something temporary they're going through and they're not suicidal. Oh, let's just say someone just lost their mother, died of old age. Well, they're probably going to get through that, but it's the next couple of weeks they're going to be pretty dang sad, and maybe doing something nice for them here or there might be enough. Versus somebody that's struggling with I've got depression runs in my family and I've got it bad right now, and where you try to get them to some professional help, and then getting comfortable with saying, people have anxiety attacks like you're having. Sometimes get suicidal. Is that I've had some of that. Do you think you're going to act on that? I don't think so. I really don't. Or, I might. Well, have you made a plan? Yeah, I have a plan I put together. I've been saving pills. But so there's different levels of asking. But asking to the point you're comfortable and then trying to, direct somebody to help. So one thing I should say probably in ending is that there's been only a few systems in the whole world where they've reduced suicide rates among a population. And one of them is in Sweden, where they took an island and they trained all the family doctors how to recognize and treat depression much better, and suicide rates came down for that little island.
Wow.
Another one was the Henry Ford healthcare system in Detroit, where they did something called that's now called zero suicide, where throughout their whole organization they checked on people and screened people and got them help. And
was that just a company? Or?
It was a company, but it was
Okay.
their healthcare system.
Okay.
For their employees. And then that program, the Zero Suicide Program, was used in Tennessee, outfit called Cornerstone, and they brought down their suicide rate. And then the U.S. Air Force, all the military suicides have been going up.
Right.
Soldiers are more likely to die by suicide than in battle now. But the Air Force is the only one that had this concerted effort with about 11 layers of different programs to screen people, to help them, to reduce stigma around getting help, to provide early help. And the other armed forces, suicide rates kept going up, and for the Air Force, they leveled out and came down. But the effort that's required is pretty major. The
Right.
system really has to invest. And I can tell you that Intermountain and the University of Utah are adopting some of the zero suicide measures within their organizations right now. And obviously there's different layers of it, and they want to expand these layers over time. What's unsatisfying about the zero suicide and they've got their own website, just type in Zero Suicide, is that they do a whole bunch of things, and then we know it works. But because I'm a scientist, I'm like, well, which part is working? Is it just this one piece, or is it all the pieces?
Right.
We don't know, but we know if you do a whole bunch of pieces at a lot of different levels, like the Air Force did, like the Henry Ford healthcare system did, and you're suicide aware. So this is interesting because my wife had a kidney stone recently, and she went into the emergency room, and they went through their questions. Have you been suicidal? She goes, what? Have you? And she goes, no. And have you, has anyone been hurting you? No, but anyway, she was surprised, but I thought it was great that, somebody really needs to see a urologist for a procedure to get rid of a kidney stone is being asked these questions. And that's the kind of integration that you and I need to see moving forward, where screening around suicide and domestic violence and other kinds of things is just part of every medical practice. But we have to layer out, okay, if somebody says yes, what the heck are you going to do? So you got to layer in the services and But
a lot easier to do on a small scale. Maybe like the Henry Ford operation.
Yeah, they were pretty big, but they probably started small and then they added to it. And the Air Force, added all these layers.
Yeah.
But it has to be organizational. And the other thing is, all the programs that worked it was leadership at the very top that adopted the program. It wasn't in a psychiatry department, or it was the entire organization took it on.
Right.
So it can't be just mental health people doing this thing. It's got to be the surgeons and the emergency room doctors. Everybody has to contribute to make the Zero Suicide program work. I love the Zero Suicide program. I don't like the name only because one reason. I love it as an aspirational goal, Zero Suicide. Mm-hmm. But I know people that have lost their kids or their loved one, and they did everything they could.
Sure.
And there was just no preventing that particular suicide. And I don't like the Zero Suicide name because it almost implicates people who've had their relative suicide that they should have done something different.
Right.
And in many cases, no, they did everything they could think of. And they were lovely people doing their very best. And so I think of it, we can keep, Zero Suicide is the name of the program, but I think we should think about it like what we've done with auto accidents, that when we added, everybody's got to wear a seatbelt, car crashes went down, fewer mortality, fewer deaths, less morbidity, people being hurt. And then when we got the airbags, it came down another layer. And so with suicide, I don't think we'll ever eliminate it, but if we can provide care in a different way in all of our systems, I think we can reduce the rates.
And then just help people know the tools that are out there to help people, right? If we're ignorant of it, then that's not going to do any good.
I think we need to get word out that we have really good treatment now, and treatment works, and it's available.
Mm-hmm. A lot of guests that come on the show talk about their dark times, and a lot of them have been suicidal or had depression.
Yeah.
And they said their saving grace has been a support group, either a family member or friends or just a bunch of people rallying around them to help them. And I think that's what I'm getting from you as well.
Well, yes and no. So remember I told you about biopsychosocial. So
right.
if let's say somebody came out as gay, and their family was rejected them or pushed them away. That could be devastating, right? So having a support group of people who've been through the same thing could be remarkably helpful. Mm. But if people in your family have had bipolar disorder and you turn 16 and your moods nothing's happening in your life, but your moods are swinging up and down like crazy, and you're going from being hyper and dancing around in your underwear at night, and you're writing a new play for Broadway, and then the next morning you want to kill yourself and you're the most depressed you've ever been, and no support group is going to fix that. That is now once you get treatment, medical treatment, and you get the bipolar treated, yes, then connecting to other people who've dealt with that. Gosh, what does this mean? I've got these mood swings I can't control, and I got to take medicine the rest of my life. That sucks. So then having a support group then it's big. But it's like it's good to be in a cancer support group, but if you don't get treatment for the cancer, how good is it?
That's a great perspective.
On the other hand, if you get through your cancer and you're cancer-free, how nice to have had the support of a group that helped you through that or even helped you afterwards get back to living. So you have to decide in the biopsychosocial where the person's at and whether they need a support group or whether they need a cognitive behavioral therapy or dialectical behavioral therapy, very
Right.
specific therapies, or whether they need a medication because they're too low to do any of those things.
Right.
They can't even talk. They can't even call their friends because they're so depressed. They can't even. They sit in therapy, and the therapist says they're too depressed to do therapy. Well, then you need a medication. So,
Sure.
and
at
I'm
the
not
same
pro.
time-
Believe me, I'm not pro. I have people come to me for medicine. And I say you don't need a medicine. Here's what you need. So I'm fine with that. It's just that every patient needs to be evaluated.
Right.
You know.
But at the same time, you may need someone to tell you, oh, you need some help. You need to go get therapy or you need to go get medication. Right?
Yeah.
Yeah.
And here's what's interesting. The really good, like a really good physician that only does, let's say, ECT, which is for the people that have severe depression, electroshock therapy.
Okay.
The really good ones will say, we help this person with their mood overall, but they have these problems. They need to be in therapy. They need, and they will refer to a really good therapist.
Mm-hmm.
And the great therapist will say, well, I've got 30 patients I'm treating now, but this one patient is too depressed to do therapy, and they need a medication. We need to send them off. So even if they don't do those things,
Yeah.
they're smart enough to think about the biopsychosocial model, and they work collaboratively with other clinicians and to look at that particular patient's needs. The really good clinicians, they don't just have a hammer in their toolbox, right? They got a bunch of tools, and they have colleagues with maybe different tools. And if those tools are needed, they refer. They work collaboratively.
Right. Great perspective. Well, this has been really eye-opening for me. I've learned a lot. I think a lot of people that are listening have learned a lot, and I hope it's been valuable to them. So I appreciate your time. I do want to ask you one more question, though. Can you give us just a success story from maybe one or two of your patients where they've come in, they've been suicidal, and you've been able to help them and see them succeed later on in life?
Oh my gosh, there's hundreds of them. I love my practice. I'm semi-retired now, and I'm doing administration, but so many. Well, here's one. I had an adolescent female that had really bad mood swings and was struggling with some suicidal feelings. And she came in to see me. She wasn't suicidal and hadn't been suicidal. And it took a while. I had to try a number of things, and she wanted to give up a few times. I'm like, no, we're going to get this fixed. We just have to try something else. We finally found something that worked, and it worked really well in terms of medication for her mood. Got her into some therapy to talk about what she'd been through because she'd lost some friends and had to drop out of school, a bunch of stuff. But anyway, later on, she's an adult and she's employed and she's a school teacher and is great and her mood's steady. And she comes in to see me and she's leaving my office. And I do a lot of pep talking people that are down because I believe I'm going to get them well, and I typically do. If not, I get them better, right?
Sure.
She was saying, back when I was a teenager, she said, you saved my life. And I go, what? You were never suicidal. She goes, I was very suicidal, but I didn't want to be hospitalized, so I never told you.
Wow.
But I always left your office with some hope that, you'd find something that would help me. And then I realized that even when I think somebody's not suicidal, don't forget the pep talk, and don't forget you're not alone, and don't forget I'm with you. And I think this podcast, I love this podcast because they can listen to a lot of people who struggle with things and realize they're not alone. It's just one added, value to the podcast. But it doesn't, whether you're a oncologist treating some kind of cancer, or whether you're helping somebody with a terrible mood disorder, whatever, giving the patient hope, and it can't be false hope.
Right.
You've got to, we have so many great treatments now. I really believe I'm going to get everybody well, and that's generally true. And again, the ones that aren't well at least get better, and they can lead their life out of the bottom part anyway of their mood. But I would just say, as somebody that's finished up their clinical career just recently, what a privilege to, walk with all these people and try to help them. And what a privilege to be trained in all these methods to help people. And I'm a relationship person, so what a fun career to have all these relationships.
Yeah.
And, an ICU doctor, that's really important, but the relationship might be 4 days. And then you go to another inpatient unit, but not ICU, for example. And I followed people for years and years and years. And I had evaluating a child, and I kept looking at the mom, and I was like, she's familiar. And so finally I said, the kids were playing, and I said, where do I know you from? And she said, this is the mom. She said, when I was 15, I made a suicide attempt, and you took care of me. You did a really nice job.
Wow.
So when my kid was sick, I was looking through the list of doctors, and I go, I think that's the Dr. Gray that treated me. And she brought her kid to me. And, so anyway, the rewards.
How rewarding is that?
Being a psychiatrist is very rewarding.
Wow.
Yeah.
Well, that's very good. Well, thank you so much. I really appreciate your work, all that you've done over the last 30 plus years. And I appreciate you taking the time and sharing your experience and your research and your insights and wisdom. And thank you for taking the time.
Glad to help, and keep doing these podcasts. They're great.
Well, a big thanks to Dr. Gray for taking time to share all of that information with us. There's a lot of practical and even scientific information that we can use to help ourselves or to help others through difficult challenges in their lives. And if there's one message I got from that, it's that there is help. There is hope. There are a lot of really good resources out there to help people deal with whatever challenges they're facing. And there's always hope. After night comes day. Dr. Martin Luther King said, "But I know somehow that only when it's dark enough can you see the stars." I hope that when we're all going through challenges in our lives, that we can see the stars, that we can find small, bright spots that help us get through those times. We're all going to face challenges in our lives, and it's how we persevere and endure and get through them that's really going to define our lives. So again, a big thanks to Dr. Gray for taking time to be with us. A big thanks to you, the listener. My name's Joe Belliston. It's a great day to be alive. We'll see you next time, and God bless.